So, our first speaker is Sandro Graca, who's a doctoral researcher at the University of Wolverhampton, UK, specializing in research on polycystic ovary syndrome and digital health. His scholarship also focuses on acupuncture and traditional complementary and integrative medicine, and he contributes to this field as a board member of the Society for Acupuncture Research, director at Evidence-Based Acupuncture, and social media and outreach editor for UGIM, the European Journal of Integrative Medicine. He's serving as a guest editor for the special issue Case Report Research in Integrative Medicine, Advancing Evidence for Complex Interventions, which is accepting submissions at UGIM. And he's a co-author on recent methodological work on structured case reporting, practice-based evidence, and the integration of case data into research and education. So, Sandro, thank you so much for agreeing to speak on this. Please share your presentation and tell us about case reports and practice-based research.
Thank you so much for that lovely introduction. It's really nice to be here with you all. And let's see if I can do this now and share this. So you should be able to see my full screen now. Is that okay? I'll get this. There's a recording here out of the way. Is that okay?
Yep.
Okay, cool. Yeah, thank you so much for that. It's really nice to talk about this. It's one of those, so this will be an interesting presentation in the sense that I need to remind myself to slow down, because I was told before that when I get excited about something that I'm presenting, I get to speak really fast. And this time I will be really excited because this is a nice progression of work combined into this presentation and stuff that is being done by international teams, all over the world. And one of them working in case reports and in practice-based research, I'm actually actively involved in myself. So that will be really, really interesting to share this with you. So just a few things, as Susan already introduced me, but just for full disclosure, there are these things that I just want to make everyone aware that I do have these, you can call it conflict of interest or really, really interest in this. I'm on the board of Evidence-Based Acupuncture and Society for Acupuncture Research, and also with a position with Elsevier for the European Journal of Integrative Medicine. And I'm also an early career researcher and social media officer for APCOS. And yes, most of my research focuses around polycystic ovary syndrome, but I still stay connected and doing research in acupuncture and integrative medicine. The talk today, the from clinic to evidence, and then the case reports and practice-based research, as I said, is something that I've been actively working on as part of one of the international teams doing work on this. And you might be thinking, everyone here, I'm sure, is familiar with the evidence, with the pyramid, and it's something that I got when I even started doing this work and thought, well, I'm so used to, like, I worked on the guidelines, the PCOS guidelines, for example. So the international guidelines for PCOS, really, really at the top. And it was my very, very first time to actually come down that pyramid and think about case reports and the importance that they have. And more so, what I want to show you today is how you, as a clinician, can get involved as well. So just to place everyone, case reports, yes, they are located at the base of the evidence pyramid. There are no control groups when we're talking about this, but this talk is going to show you why this base matters more than you might think. So when you talk about case reports, you know that they are patient-centered. They give you like that in-depth snapshot of what's happening in your clinical encounter with that patient. It's real world, so it's happening in your clinic or it's happening in a hospital, or it's your medical encounter with that person in front of you. And it captures that individualized treatment, which I'm not in clinic anymore, but I was a clinician just like most of you here today. And we know that what we do doesn't fit what you would see, for example, in an RCT, because our treatments tend to be quite individualized. And for what happens when we are seeing a patient sitting in front of us, that case report will document a complex system phenomena. So there's the interaction between you and the patient. There's, even if you think about multiple treatments, multiple sessions, that everything that happens in your treatment room, that could include acupuncture, herbal medicine, all of that is a very, very complex. And it's something that, again, it would be really, really difficult to capture in one RCT. So I'm sure that I've heard this a lot of times. I'm sure that you've heard it too. You've seen it written online that um, for this particular talk, I'll focus more on acupuncture because that's more of the work that I've done. But, for integrative medicine, you hear a lot, there's not enough evidence. That's one of the things that you hear all the time. And just without naming any names, Susan and I were at a conference recently, and one of the presenters said something, and I'm just paraphrasing here. It wasn't exactly this, but something that I've heard a lot too, and I'm sure you have as well. I've been seeing patients in my clinic for over 30 years, so I can tell you that acupuncture works because I see it working every day. And I've done that too. I've been in clinic for over a decade. I saw it working all the time, but that was just me. And I did not write about any of that. So what I want you at the end of this lecture is that when this happens again, because it's likely that it will happen again, that you will be able to, okay, maybe not that abruptly, but say, stop talking and show me the data, show me those 30 years of work that you have in your clinic, and that you can actually refute that claim that there's not enough evidence, and not only refute it, but be part of the wave that will add to the amount of evidence. So by the end of this lecture, you will be confident about what are case reports. You will know why case reports are extremely important. You will understand the value and the crucial role of clinical data. So what you are creating every day in your clinic. You'll hopefully be motivated to write your first or your next case report, and you'll feel prepared to submit that first or next case report for publication in a peer-reviewed journal. And you'll see why that is really, really important that you share that information with others as well. So just as a little bit of I guess, a disclosure as well, you might think about why would I care about case reports? I came in to do work with this particular international team when the work was already ongoing, and probably like most of you here had to go and learn a little bit more about what case reports actually are. So this is where I started. I read the CARE guidelines, so the name comes from the case reports. They were developed by an international group of experts, and I then got involved in this project, and just as the CARE guidelines were before, these ones were being developed for Chinese herbal medicine. And that group of researchers included people from the UK, from Australia, and from the US, and probably some of you here listening to this as well, because there was a lot of um, this was done with, I think it was 61 practitioners. There's more information further ahead. But this was done with clinicians. And I thought it was really interesting. And that's what captivated me, because at this stage, I was doing research. I was doing research with patients. I was involved in both acupuncture and PCOS research. And now I was seeing research that was being done with other clinicians, just like I was at the time. And then with SAR, with the advent of the special interest groups, one of the special interest groups that was created was the practice-based research. So research that can be done while you're practicing. So this is how I got involved. And throughout those, I was already involved with this particular group in the US, the Society of Hospital and Healthcare System-Based Acupuncturists. And I got to know more about clinicians that were actually working in either hospitals or healthcare system based. And it was interesting for me to find out how do they get to work there, and how do they stay there? How do they develop their practice within that healthcare system? And telling those stories was really important so that they could document what they did to get there, what they were doing while there, and what they have done to develop their own position while working in this system. And I'll show you a few examples later on. So you might know that historically case reports have been important for recognizing new or rare diseases. And we all know about the impact that COVID, for example, had on that, where there was really, really a big search, because that's what all that was available was for case reports. They were important for evaluating the therapeutic effects, adverse events, which was something that we still see a lot of those case reports being published, and costs of interventions. and also the improving the problem-based medical education. So this is something that I wrote about before as well, and I'll tell you more later on. And it would be something that I would really, really like to see acupuncture schools or integrative medicine schools of all kinds actually educating the students on how to collect data in a way that it's important for them for clinic, but also that could be used for writing up a case report. So this is how I got involved. And I will now talk a little bit about how I would like you to get involved and why this is important. So as I said, with SAR, we have a special interest group that is called practice-based research. So this is looking at research information that would be coming from clinics. So what you're doing and how you are doing it to give that information to us. And as Susan mentioned at the start, if you're watching this within the next few months, I'm also involved with a special issue in the journal, the European Journal of Integrative Medicine, accepting case report research. So case reports and other pragmatic data sources, such as clinical registries, so this is involving the data that you're already collecting in the clinic, they give us that opportunity to observe and learn from your real-world clinical encounters. So exactly what you are doing in clinic in your own way. It provides a research model that more closely reflects actual practice than RCTs. And these single case reports are actually important to inform clinical practice for TCIM clinicians. So that's traditional complementary integrative medicine clinicians, because they draw that comprehensive, holistic picture of one phenomenon in a real world clinical setting. So everything that is happening in that encounter is being documented, and you're writing about that. More importantly, I guess, for me, because I'm now a researcher, that information from your clinic and from your case reports, that informs future research questions and clinical study design as well. So this will solve a problem that I will talk to you now. Um, when I worked on the very first paper that I got published, that I worked on, this was Deborah Betts. I wish I could claim this title, but it was actually Deborah Betts that suggested we should call it that. And I'll leave it at that, why we didn't go ahead with this name. But we were looking at the clinical reality of what happens in acupuncture clinic. And within the two group of papers, one of the things that really, really stood out for me was one direct quote from one practitioner said that acupuncture research is irrelevant to my practice because RCTs can't reflect the individualized treatment I provide. And that really, really got me because I was really into research. I'd finished my master's. I was thinking about starting my PhD, and I was a little bit taken back that my colleagues weren't really into research, and I wanted to know more about why. So one of the things that they also mentioned is that to be meaningful, the research that they wanted needs to be adapted to reflect an individualized approach and capture their clinical experience. So what exactly they do in clinic. And they actually suggested that this could be done through case histories and collecting clinical data. So this is really important. This is from the date, I think, was 2018, 2019. The papers were then published in 21 and 22. And even at that stage, the hint was already there. And this was coming from clinicians. So I got into research because of Professor Hugh McPherson, and one of the first papers that I probably remember reading was this that actually came from the group at SAR that talked about the paradoxes in acupuncture research. And this paper, which was from 2011, already mentioned this dichotomy of acupuncture not being able to be studied through an RCT. But actually, this group of researchers that, at the time I wasn't even thinking about going into research because I was in clinic, but Professor Hugh McPherson was already talking about this and saying that they disagreed. So it wasn't so much that acupuncture couldn't be studied using RCTs, it's just that instead of having that idea, it's maybe that we need to find better, so we needed the patients and to find better tools to find a way to study exactly what happens in that clinical encounter in the clinic. So one of the first papers that I worked on as part of SARS being on the board was with Claudia Sitkovits, and we worked on this paper that was this idea that you hear all the time about from the bench to bedside and back again. But what we wanted to really, really emphasize was that extra bit. So we had the evidence-informed practice. So evidence and research that is informing your clinical practice. But we also wanted the other side of that, which was information coming from your clinic to go and influence future studies, future study designs, and the way that research in acupuncture is done. And this is where I kind of started to get that idea of how clinicians could be involved in this important part of research. So I'm just going to give you a quick overview of 4 things that case reports can do that RCTs can't do. So the clinical description and hypothesis generation, so new observations surface through case reports, so something that you've realized in clinic, something that is different that you had not seen before. So I'll give you the example again of COVID. Nobody had seen any of that before. Nobody had seen any of the reactions. That was all that existed, was the information through case reports. So it's the raw material for evidence. Then you have safety. Obviously, as I said, one of the main things that I remember reading from the very, very early days was case reports talking about adverse events. So this could be adverse events, but could also be rare and unexpected. And you can't really design a trial for that, so you report those through case reports. Preliminary efficacy for rare conditions, again, where RCTs are impossible, the case level evidence builds and would be the only available picture because it's either rare, so you wouldn't have enough of that population to study, and might just be that an RCT study is just not feasible to learn about that condition. And this is really, really important for me. And I would really, really like you to understand this point that it's really, really teamwork and we're all contributing. So the case reports will contribute to feeding the evidence pipeline. So starting with a case report, a systematic review of case reports, cohort studies leading to RCTs in the future. Now, this is a real pathway. This is not a consolation prize. So you are part of the chain and you are a really, really important part of the chain. So just to give you an overview, this is nothing new that I'm talking about now. Case reports have been around for a long, long time, and I'm just going to give you a quick overview since the 2000s. So you have there in the year 2000 a publication talking about just approximately 42,000 case reports published in PubMed index journals. Between 2000 and 2010, there was a 45% rise in case report publications in index journals. So that took it from approximately 42,000 to 62,000 per year. And then you get to this important landmark time of 2020, where you have almost 90,000 case reports on PubMed. So that's 110% growth rate since 2000. And then this is where you really, really see the big difference because of what happened with COVID, with those 20,000 plus COVID-19 case reports on PubMed. And this continues to rise. And it just gave, I guess, a little bit more credibility and relevance to the case reports that were a little bit almost like forgotten. And all of a sudden it was like, oh, okay, this is actually really important and we could use it as tools for other things as well. So let me give you a few real world examples. So here's a systematic review of case reports. So this is 22 case reports spanning 40 years, 211 athletes across diverse sports, and they were published between 1980 and 2019. So why is this important? So elite athletes are really hard to recruit into trials. So think about if this was you. They're very heterogeneous, they're high stakes, they're poorly motivated to enter an RCT because there's a lot on their mind and being an RCT is the last thing that they would be considering, right? So this systematic review of case reports is the only systematic evidence available for acupuncture use in this population. And it provides a lot. You can see there that this is from the paper published itself, the systematic review, and you can see that there's conditions throughout the whole body that you would not get any other way other than putting all these case reports together and show it as a systematic review. Another real world example, this is way, way closer to me because I know the main researcher. Matthias is a good friend of mine from Austria, and I actually allegedly nagged him a lot to publish a case report because he works in a palliative care unit in a hospital in Graz in Austria. And he sees these interesting reactions to acupuncture every day. And he actually had another one in Chinese herbal medicine as well, which kind of gave him the idea of publishing something, but he then didn't. And then this one came along about acupuncture, and I kept asking him to please, please publish this one because it was really important. And the way that I sometimes talk about this one is if you think about being at a party and telling someone that you're an acupuncturist and people don't know about acupuncture and it's like, oh, you stick needles into people, does it really work? Whatever. If you were to tell someone that you used one needle, one acupuncture point, and the person got better, I would say that no one would believe you. This was something that happened in the palliative care unit. It was written, it was published in a peer-reviewed journal, and now it's there forever because this happened. One acupuncture point, and immediately after acupuncture, the patient reported complete pain relief lasting for 1 day. And that helped the treatment itself on the long run because the pain was then better manageable with reduced dosages of opioids from that point onwards. 1 point, one needle makes a difference. And now it's not a story anymore that you tell at a party. Now it's a case report that has been published and you can rely on. This brings me to think about and to give you another example, because as you see, Matthias is one of the co-authors of this paper I wrote a couple of years ago, where I talked about these green shoots of acupuncture implementation in healthcare. So I got Matthias from Austria, I got Beverly from the UK, and I got Bobby from the US, because I wanted to give a little bit of a different perspective, different healthcare systems, even different languages in the case of Matthias, and just see and I titled the paper, Are We There Yet? Like the inpatient child in the back of the car. Are we there yet? Are we there yet? Are we implemented now? Are we part of the healthcare system? And this is what I wanted to see. And it really stood out from this paper and from talking to these clinicians that what is reported gets implemented. And here's an example from Bobby's hospital. So a colleague of ours, Zena Coker, published this case report talking about acupuncture for preeclampsia. There was nothing else that they could do with this patient. There was nothing else that they were going to be able to do with helping that woman. And Zena used acupuncture and wrote the case report with Valerie Hobbs, ends up being published, and now it's there forever. What that means is that then it gets seen and it stays implemented, so much so that you can read there that someone from the hospital said, this research suggests that acupuncture or acupressure should be part of our toolkit in decrease preterm delivery and improve outcomes for women with preterm preeclampsia. So remember, this is why it matters that you are involved in this and you're a big part, because you need to write these things down, because what gets reported might just well get implemented. So at this point here, I would like to remind you that whether it's a very, very strange case that you see in your clinic, that something that surprises you, or if it's something that wouldn't be usual or feasible to test as an RCT, this is where really your data comes into play. And your data from your clinic is really important. So you need to be collecting data that makes sense, that is able to be sorted, arranged, and then this is where, I guess I always say that where the magic happens, because then when you start seeing things like the systematic reviews of case reports, or as I'm going to show you next, having all the information then collated and presented together, then you start to explain that data with a story. And even more importantly, you get to use that data to become actionable. So what this means is that other people get to learn from your case reports, get to learn from what you're doing in your clinic, and they get to do it for themselves as well. So let's just be very, very clear about what a case report is and what a case report is not. So case report is a narrative that describes for medical, scientific, or educational purposes a medical problem experienced by one or more patients. This is why it needs guidelines, because it needs to be uniform. So they all need to be, you'll see this in a little while when I show you, they need to match, because the data, like for example, for that systematic review, the data needs to match. Otherwise, it's just different fragments of data that don't match at all and don't go well together. So the case reports are written without guidance from reporting standards are insufficiently rigorous to guide clinical practice or to inform clinical study design. So this is why the guidelines exist, okay? What case reports are not are just case histories or random bits of information that you collect from the patients that you're seeing. And I am always the first one to put my hand up. This is what I did when I was learning, when I was doing my licentiate in TCM. And so much so that I use this picture in my presentation because this is a picture from my own classroom. This is not my year, but it's a picture I found online from my own college. I remember that room. I remember the banner in the background, and it just reminds me that no one is above anything. I made the same mistakes because I was writing case histories. I was writing little bits of information. That is not information that is enough for a case report. So case reports are not a simple case history from a technique-based training program. They are not a clinical note or a patient file entry. They're not an anecdote or informal peer discussion. You know, I saw someone in the clinic once, or there was this patient once. That's not what it is. And the reason being that, just to really emphasize this, that without guidance, all of the above are insufficiently rigorous to guide clinical practice or to inform study design. And this is really emphasized on the paper that we wrote, saying that we need the information to be rigorous. If you want the information from your clinical expertise and from your experience to go back and influence the way the trials are conducted and are designed and conducted, it needs to be rigorous. So what case reports are documented with informed patient consent. This is really, really important. You need to get informed patient consent. They're written to reporting standards, for example, the care guidelines. They're published in peer-reviewed journals, and they are academically rigor in data collection and the analysis as well. So how this benefits you, just so that you don't think that this is extra work for you as a practitioner and as part of your toolkit and as part of your expertise, learning how to collect data in this way that can go and facilitate writing a case report helps you by getting you familiar with research methodologies and reporting standard guidelines, so you get better in your knowledge. It helps you with your systematic documentation and reporting. So you will find that you will get much better in your clinic when it comes to writing down your information from the patient, because now you're way more structured. And more importantly, it will encourage you to critically evaluate your treatment outcomes. By this, I mean that you're collecting more similar data, so you are able to go back and see in, for example, a patient that you have seen for a while and see how were they when they came in first, how were they at 3 months, how were they at 6 months, how their condition developed, how your treatment developed, how they responded to the treatment. This will be way better for you because you'll be able to then go back and read what acupuncture points you were using within those first few treatments, what acupuncture points you were using 6 months later when the condition had changed. Because to try and recall that from top of your mind or with poor clinical notes, you will never ever get this information that you would be able to get if you're collecting data this way. So this is going to be really, really brief because you can get this from the website. So just for you to be familiar with what the checklist looks like. And this is a little bit of reverse engineering in a way, because this checklist is for when you have written your case report, but you can use it to make sure that you are now collecting data in your clinic that will satisfy all this that you need for the checklist. So the top is just for the title, the keywords, abstract, because I just want to go through this because there's something at the end that is really, really important that I really, really like. So you have information about the patient information, the introduction, what goes to write your case report. It may include references, so you need to cite other work, the clinical findings, the timeline, the diagnostic assessment, therapeutic intervention. You have follow-up and outcomes. So this is what I was saying to you, that it becomes really, really good for you to make that assessment of your own clinic. Discussion. And here again is where you will get references and you will link what you found with previous work. And then this one that I find really, really interesting, and it should be for you as well, which is the patient perspective. When possible, the patient should have their perspective in 1 or 2 paragraphs in the treatments they received. And this is really, really powerful, because if you've ever been involved in trying to get acupuncture into any healthcare system, you will have realized that sometimes the patient's word is way more powerful than our own, or even more powerful than research. That happened to me when I was working in Dublin, that the word of the patients and what the patients wanted in the fertility clinic was more powerful than just us saying that, yeah, acupuncture is really, really good for those patients that are going through fertility treatment, and here's a bunch of research that you can read. Patient's voice is really, really important. So this is another thing that I really, really like about the case reports. And just at the very end, you see there as well the informed consent. You really, really need to make this clear that you should always have informed consent from the patient. So this you can get from the website. So this is all easy for you to have a look at. So there's no point in going through that in too much detail. But along with that website, and just to let you know that this is not isolated, there's this big, huge network. And this is an active, internationally coordinated field. And this is not just for bureaucratic checklists, just to make sure that there's a checklist for this and there's a checklist for that. These are guidelines. This is not adding any extra work for you. If anything, it's just making it more systematic. But these ask you to document things that you already know, things that you're already doing in your clinic. You just need to be really, really good and consistent at collecting them, so that then you can go and write your case report. So when you go to the Equator Network website, you'll also see that there's extensions that could do different aspects of integrative medicine. So you have one for acupuncture specifically. You have one for adverse events that you can find there. One for Chinese herbal medicine that I'll talk to you about in more detail, just for you to see how this thing comes about. There's one for dry needling, which, funnily enough, I did not know about. And it was just when I was preparing this that I actually got to read the paper, because it's from 2026. There's a few colleagues of mine that I know well, Paul Battersby and Tianjun Wang as well, were involved in this. And there's others. It's not just acupuncture. For example, there's one for physiotherapy, and there's one adapted for therapeutic massage and body work as well. So these are great to guide you on what you need to be collecting in your clinic. So how the Chinese herbal medicine ones came about, this is, I can give you a little bit of an insight because I was part of this group. So for Chinese herbal medicine, the issue in terms of the documentation is that it has documentation needs that are not covered by the generic care guidelines. So the ingredients, the preparations, the dose, the formula rationale, that was not covered by the care guidelines, and this new one now actually fills that gap. So again, we published this. It was published for everyone to access, and it was co-designed. So clinicians were part of this. So there was 18 Chinese herbal medicine practitioners from 4 countries, 5 separate group discussions, and then 61 items were included in this guideline. So this is, again, very, very clear. It's easy for you to use, and you can look at it and then just adjust the way that you're collecting data in your clinic to make sure that you can fulfill the writing a case report. These are really, really important because systematic reviews of herbal medicine case reports would require this standardized source data. So things like your, again, the ingredients, the preparations, all of this needs to be standardized. And the CHM care ensures that raw material, so that core needs for conducting this research exists in answer to answer these questions, not just from safety, but also from clinical practice patterns that, as I said, can keep going up that pyramid of evidence all the way to the top. So for you, as part of your own development, why this is important is it can actually act as professional development for you. So by regularly documenting and analyzing your clinical experiences through these published case reports, you can refine your practical skills and be up to date in your research. So this means that you can also contribute with your own research, but you can also learn from the most up-to-date, as I said to you, the things that are just emerging now that might not be documented or might not be in an RCT yet. And by reading those case reports and writing those case reports, you're taking and giving back to the evidence as well. So it will help you because it will sharpen your clinical reasoning. You're documented your patient assessment, your treatment planning, you're thinking about it more, and your outcomes, all of that builds your metacognition in the clinic. Your research skills get better because you get to learn about the systematic data collection, your critical evaluation as well, because now you get to look at your full spectrum of your clinical practice. And those are the same skills that will be really, really valuable for you if you weren't reading clinical trials before. Now you're more involved in research all the time, so you'll be able to read more of the trials as well to inform your clinic. Interdisciplinary communication, now you're able to publish these and talk to other clinicians about your publications and what you are really doing in the clinic, explaining to them how that clinical encounter actually takes place in your clinic. And it's your contribution to the evidence-based. So each of your cases or each of these cases published adds to the systematic body of evidence for integrative medicine. This paper that I got this information from was something that I, again, with a few colleagues from the US and from the UK, we published about this. We even included a little bit of talk about the issues in the US with education and how using this more systematic way of collecting data and contributing to the evidence-based might be more interesting to capture the students' attention and motivate them. But more importantly, really towards that right-hand side there, the practical approaches, it's really, really important that you document what you're doing in clinic because that will really, really inform the study design and future of acupuncture. Because what you're doing, I always say to everyone, what you're doing now, how will people in the future know about what you're doing in your clinic? You might be doing something that would help a practitioner in Germany that is seeing the same condition and just hasn't been able to shift that in that particular patient. So please document and publish what you are doing in clinic because that can help other colleagues and it will most definitely help for the future of the profession. Now, as I said to you, I've been in clinic before. I know that we are a little bit of a we do a little bit of everything. We try to help the patient as much as possible. And for someone looking in from the outside, what we do might look a little bit stranger. So order and chaos might take a little bit of a different perspective when you're looking at what we're doing. So what we decided to do to look at, is this feasible within the clinical arena when you're taking this data down as clinical registry? We put this work together, again, with the same team that was working on the case reports, and we looked at 12 case reports and 130 clinical registry records. And what we wanted to see exactly was how this data was being collected. Can it be standardized? Is it actually able to write a case report? Is it feasible to think that this data is good enough to tell us the full picture of what's happening in that clinical encounter? And this has been really, really interesting to work on. So the reason why this is important is because the case report starts with your clinical data. Any research, any information for the future starts with what you are doing. So if you think about your clinical data to write the case report written to standard, they became a data set. So like you just saw from that systematic review. And that data then becomes, you can combine it, you can analyze, and you are capable of answering questions that no single practitioner could address alone. Because now you're combining the same from could even be different parts of the world, right? So research questions that this type of work can answer include, how does diagnostic reasoning evolve in complex cases? So just as I was saying to you, what changed throughout the months that you were treating this patient? What patterns exist in practitioner treatment decisions? So what influences your decision for how you're going to treat that patient or those patients in the case of looking at different data sets put together? How do patients change their self-care behavior over time? This was something that was really interesting to see from the data as well. And what nonlinear phenomena appear in traditional East Asian medicine treatment? So what any other things are there that we weren't expecting that are happening in your clinic now that we can see all of this data coming from you, is there anything that you couldn't see just by one data point alone? So here's how data from the clinic can really be interesting. So here's one audit. This is from the UK, and it's from multi-practice outcomes. So 232 patients, 233 health outcomes. So you can see that from a clinic, almost half, like 46% of them being musculoskeletal. That's probably what we would normally see in our clinics. And then you can see the follow-up completion rate, almost 62%. And this is really interesting. So the patient global perception impact, I always get confused about the PGIC, but 90% there of the patients saying that at least minimally improved. Now, the key findings from this particular one was the clinically meaningful improvement sustained in the medium to long term. So we can see that from all this data from the clinic, we can see that to medium to long term, the treatments are making a difference. But there's always a but, right? That 90% improved reduces to almost just over 50% when you control for missing data. So that's really important because a lot of the data was missing. So you can't actually talk about the 90% improvement because when you control for that, only just over 50%. Here's another example, single practice. So this is from one practice only. Again, majority of it musculoskeletal, a big patient and global impact. I can't ever remember what the PGIC, this is annoying me now. But the 93%, 79% with the MyMop were saying that there was 1 point change in their MyMop. So this was really good. And 50% mean severity reduction showing on MyMop overall. What's really interesting from this particular paper was that the wide range of predominantly chronic complaints, and many of these had limited existing evidence. So very little existing evidence for these conditions, but they are being treated in the clinic and they are showing results in the clinic. So this data could contribute to make an impact for maybe implement acupuncture for that particular condition in a particular healthcare system. Now, this is very important because this only exists because the practitioners documented their work. So this data pipeline, this idea of evidence existing and evidence being out there, it starts with you. It needs to come from the clinic. If this wasn't documented in the clinic, we would not have this information at all. So it starts with you. So what are the main issues that I was talking to you about so far? Insufficient data. That's the main thing. Like, I know we're busy in the clinical practice, but we need to have this data written down. Otherwise, you can't look back, you can't report on that, and otherwise, it's just a story. It's just something that you recall that may or may not be correct, and it's a story. It's not real data that you can use and that you can contribute to the future of the profession. So when we looked at, just to give you a quick idea of why it's important for you to look at the way that you're collecting data in the clinic, for this particular work, the quantitative data, we were looking at ICD-11 as well, and Bo and I were tasked with this great work of doing the data analysis of clinical data. And it was, I have to say, it was daunting, but it was actually really interesting to see getting this snapshot of what happens in clinic. So I'm going to show you some examples of real live data from the clinic. I don't know who these practitioners are. It doesn't really matter. These are just details that I'm going to show you from the clinic. Okay. So this is what it looks like. The particular data entry point asks for what was your main diagnosis for this patient. So this is electronic data collection in your clinic. And it clearly says that it's the main diagnosis. So here's one example, dampened phlegm. That's what this practitioner wrote in this particular case. Another practitioner wrote dampened phlegm. Also, quite chesty today. Is he coming down with something? Another practitioner, in another example, wrote all of this. spleen chi shu, damp heat, repeated invasion of heat, wind cold, etc., etc., etc. Remind you again that the entry point in your clinic says what was your main diagnosis for this patient. Another clinician wrote heat, liver, blood, shu, spleen, I guess, chi, shu, damp, heart or heat, chi, shu. Don't know what that is. There's no commas. Don't know what belongs to what. Don't know how to interpret that data. Another clinician wrote heart, blood, stagnation, I suppose, liver, yin, shu, and then treatment principles. That's not what this entry point asks. It asks for the main diagnosis for this patient. These are treatment principles. Another example just wrote clear phlegm. That is not a diagnosis, right? Now, I'll give you an example from clinicians that know and wrote case reports. So they have gone that practitioner development that I talked to you about, and now are writing case reports. Here's their data entries from their clinic. Yin deficiency, heat, heart blood deficiency, spleen chi deficiency, lung chi deficiency, liver chi stagnation, chi and blood stagnation. As you can see, way cleaner, way better, way easier to interpret, not just for a researcher, but also for yourself in the future to go back and actually remember what you wrote about that particular day. That's the difference between you having that little bit extra, dare I say, care, pardon the pun, but care in collecting the data from the clinic and just writing something in that particular box. So this is where I get to the end of the presentation, and just to let you know that it's really, really important that the data that you bring forward matches. It doesn't have to be the same. It doesn't have to be all equal, but it matches. It's able to be analyzed together. It needs to make sense. For it to be important, and I'm just going to re-emphasize this again because it's really, really important, it matters for the base of the evidence pyramid because the base is the bigger portion of the pyramid. It needs loads of information there. It's the foundation of it. So remember, it's crucial, and you're already doing it in your clinic. It's patient-centered. It's in-depth snapshot of what happened in that particular moment in the clinic, real-world clinical encounters, captures your individualized treatment so you can talk about what you did that was different, that wasn't just standard acupuncture treatment, or what you added extra. All of that can be documented because it's for complex system phenomena. Whenever an RCTs are impractical or it's impossible, when the conditions are rare or heterogeneous, when individualized treatment is essential, or just when you need to record adverse events. That's why case reports are really, really important, and why you should know about it, and why you should be collecting data that goes towards them. I have a call to action for you all here, watching this live or the ones watching this after. 3 simple things that you can do after watching this. Become familiar with the guidelines. Go to the website, download the care checklist, look at the Equator Network and look at the different extensions that exist there, and look at the way that you're collecting data in your clinic so that you are collecting enough data that could go into writing a case report. Then think about a patient that you have treated recently who was just interesting, or an unusual presentation, unusual reaction to the treatment, particularly if it's one that an RCT would never have been able to enroll that patient because of their condition or their presentation, whatever it was. That special one, that's your case report. Think about writing about that. And then start writing. And please aim to publish in a peer-reviewed journal, because then you can share with your colleagues and they can learn from your clinical experience as well. And you leave this for the future of the profession as well. So this is up to you now. Remember, I said it. It's the base of the pyramid. It needs loads of information there. Just because it's at the bottom, it doesn't mean that it's less important. I have a quote here from the paper that I wrote. The way to construct a strong pyramid of evidence starts by ensuring that its base is solid and robust. That's you. That's where you come in with your information from your clinic, because you're doing this every day. So you just need to document it and then go from that documentation into publishing as a case report. I'll leave you with a beautiful picture that is just from the lake outside where I am in Switzerland, where I live. And I leave you with a quote that my granddad used to say, from my granddad. I was born in Portugal. And my granddad used to say that everybody wants change, but nobody wants to change. And this is my call for you to please change. If you have to adapt the way that you're collecting information in the clinic, just make sure that you make that little change so that you can contribute to the future of the profession. And I'll leave you with that to answer some of your questions.
Thank you so much, Sandro, for a very inspiring presentation focused on acupuncture, but relevant
Mhm.
across many modalities. And I think, we've had some questions come in. So we're almost up in terms of time, but I hope we have time for you to address
Mhm.
particularly a question came in about informed consent from a patient who was seen years ago, and the practitioner is no longer in touch with this patient, who's no longer in touch with the clinic. What happens in such a situation?
Yeah, this is a tricky one. That comes up a lot, and that's just unfortunate. And that goes within the context of what I was saying to you before about the changing of let me just I need to stop share, right? Yeah. Um just that these are the little changes that you might have to do in your clinic to make sure that this happens from the very beginning, rather than retrospectively having to go and contacting someone that you may or may not be able to contact anymore. So in that scenario, no, if you can't contact the person anymore, no, but this is part of those little changes. Make sure that from now on, when you're collecting that information, that you already include that as part of your intake.
Yeah, there's really no way around it after the
No,
fact. Yeah.
no.
So we also had a question, does herbal medicine have clinic trial report 2 instead of fact? And I'm not sure if the person who asked that question wants to turn on their
Yeah,
audio
what does that mean exactly?
and say more.
Yes, a lot of those plants, their use are published about according their effect, but it doesn't show the detailed case. So is anything like a herbal can be used for the case report, like what the patients, how to value the herb or something like that?
I'm not sure if I understand what you're asking me there. So remember that so I'll just give you again the background of this. This is not, when you're collecting this data, this is data that is from your own treatment. So you're not changing anything in your own practice. If anything, you're changing what you are documenting and how you are documenting it. So when you look at the CHM care, that was actually designed by clinicians. So it was clinicians throughout Delphi style process that said that, things that moved from one Delphi to another, and they said that this is what's important to collect when we are in clinic. So all that information is not new. It's not something that you need to ask new or different from you doing it in your clinic or from the patient themselves. So it's just a different or a more detailed or more systematic way of you collecting that data in the clinic, that it exists, that if you were to take that patient's treatment, you would have all the information needed to write the case report.
Thank you, Sandra. I hope that answered your question. If not, I'm sure Sandra would be
Mhm.
happy to get an email and
Yeah.
respond with
Yeah,
further
yes, I
information.
think I can get like a if like a herb like this market if I got a market words documents from the websites, but mostly it is a common factor. It doesn't have a special case related. It's those kind of things exist.
Yeah,
So,
yeah, I'm happy enough for you to email me and you can show me that particular case and then we can just take it from there.
okay.
And yeah, I can help you out with that. Yeah, sure. Yeah,
And
happy.
we have a third question.
Mhm.
All right,
Why
thank
not
you.
descriptor noted as ICD-10 diagnosis?
Oh, interesting question. So that is because the ICD-11 is the one that includes the traditional medicine.
Yeah.
So we looked at ICD-11 because this is interesting. That question came up when we were working, designing that particular protocol. And the reason why is just as simple as that. So I know that a lot of places, I'm sure there's still places still using ICD-9. I wouldn't be surprised. And, I'm not putting anyone down or anything. I do know that a lot of places are using ICD-10. The reason why we wanted to use the ICD-11 was because those are the ones with the traditional medicine codes. And one of the things I didn't show here, but it was part of a presentation that we did for SAR, for example, and it's part of the paper as well, is where we were then linking and tracking the codes from the clinician in the clinic and linking those with the ICD-11 TM. So that's what you could see on that slide, is because the ICD-11 are the ones that include the traditional medicine codes.
Thank you, Sandro. I had a quick question myself. So I understand the issue with informed consent when you have an individual patient and a case report that you want to write up. You also had clinic-based sort of data showing patterns and so on. Does that also require informed consent on the part of all the patients?
Yes, absolutely. Yeah. So that was something that came up in one of our workshops, and it was really interesting to hear that, the answer to a similar question to that coming from someone working in a hospital and really putting it into perspective where you could really see this happening. If it's your story, you'll be able to identify yourself.
Yeah.
You know what I mean? Like you could say that, oh, I'm writing this and I'll anonymize the person. They won't know it's them. But if you happen to read it, you'll know it's you. Or someone from
See,
your family or someone from, related enough that knows a little bit about you and will be able
yeah.
to identify you. So yeah, the answer to your question, Susan, again, goes back to that the building blocks of how you're collecting that information and just saying just adding that to your own clinical intake, that it says that if there is, whatever, I don't know exactly how that would be worded. Again, I'm not in clinic anymore, but you would have to have something saying that the anonymized data could end up being as part of a report. And yeah, you just have to anonymize as much as you can, but just
So you
put
have to
yourself in the
plan ahead
shoes. Yeah,
for that sort of situation. Yeah.
yeah.
Oh,
Uh,
and I'll just follow up. So on the